And Dr. Bancha
Yes.
gave a lot of lectures regarding the meniscus, and we invite him.
Thank you very much for the invitations. I'm Dr. Bancha from Thammasat University, Thailand. 早上好，我是周天才。My Chinese name is Zhou Tianchai. Is from Chaozhou, my ancestor. Okay, so very happy to come back to China again. Always happy to join the meniscus talk. It's my great privilege to join the second Meniscus Repair Summit in China in the theme of all tear, all repair. Okay, so I'm talking about the meniscus root repair, the two tunnels technique. Thanks my Malaysian fellow for preparing the information. So the topic today is about the meniscus. I start with anatomy of the meniscus. You can see that the lateral side is more mobile comparing to the medial side, right? So today we are focusing in this area, okay, the root, the medial and lateral meniscus root. So it's very easy to remember the picture of this anatomy of the meniscus root. 6, 8, 10, 12, increase every 2 millimeters. The posterior horn of the medial meniscus root is close to the PCL, and the anterior horn of the lateral meniscus root is very close to the ACL, okay, as shown in the pictures. So this is the meniscus function. The meniscus function root is to convert the axial load to the hoop stress, and 50 to 70% of the knee joint load was absorbed by the meniscus. Biomechanical studies by Robert found that the tear of meniscus root is comparable to total meniscectomy. The lateral meniscus compartment is similar to the medial side. 50% increase in peak contact pressure after the lateral meniscus root detachment. And after the repair, the native contact pressure come back. We're talking about the natural history of the meniscus. Once the meniscus is torn, the meniscus will detach from the tibial plateau. This will alter the knee kinematics. Then meniscus will be extruded more and more, and finally diminishing the hoop stress effect, resulting in rapid progression of the osteoarthritis of the knee. Many articles mention about the natural history of meniscus root. One article found that 1/3 of the patient need joint replacement 3 years after the initial diagnosis. From JBJS 2009, mentioned about the high correlation of spontaneous osteonecrosis and the meniscus tear. They conclude that 80% of spontaneous osteonecrosis of the femoral condyle associated with the meniscus root tear. Like these patients, this is my Japanese patient. She has meniscus root tear, okay, and treat conservatively. 2 years after that, the patient have spontaneous osteonecrosis and need joint replacement. The incidence of meniscus root tear is very high in total knee arthroplasty. Let's say 80% found root tear when they do the joint replacement. These are the differences between the medial and lateral meniscus root tear. The medial root tear is common in middle age and can be chronic repetitive injury, can be from minor injury like squatting, twisting, okay? And always the radial tear close to the root, about 9 millimeters. For the lateral meniscus root tear, is totally different. It happened in the young, acute traumatic injury, and always combined with the ACL injury. So this is one of my patients. They have the lateral meniscus root tear. You found that the patient have more rotational instability, severe pivot shift test. Okay, so if you find the patient have severe pivot shift test, thinking about the lateral meniscus root tear too. These are the risk factors of the posterior meniscus root tear: wireless misalignment, increased BMI, female, and high KL grading. So this is a clinical presentation of the meniscus root tear. The patient would have pain on the medial joint line. Okay, McMillan test will be positive. Okay, they have pain when walking and squatting. Examination show that the joint line tenderness, McMillan test positive, and severe pivot chip positive on the lateral side. This is the clinical picture MRI in meniscus root tear. You can see the extrusion, ghost sign, crepe sign, and myeloedema. Okay, from the MRI. Be careful. The lateral side is more difficult, often misdiagnosis. About 33% miss on the MRI. The normal lateral meniscus root should be like Y shape from the first picture. Okay, that be Lisberg ligament and the root, right? This is the normal meniscus of the lateral side. Sometimes you can see there's no gap on the lateral side, but it's just floating like the third picture, like because of the Lisberg ligament is still there. Okay, this is a Laplace classification. The most common type is type 2, the torn radial tear about 9 millimeters from the root. So how about the root repair outcome? So a meta-analysis found that the root repair outcome improved in all studies, but anyway, 50% had X-ray progression. Even the clinical is better, meniscus heal, about 50% still progress at least 1 grade of KL at 4 years of follow-up. So the paper in arthroscopy 2019, they compared the outcome after medial and lateral meniscus root repair in 141 root repair. They found that the lateral side have better outcome comparing to the medial side. Okay, so the lateral side outcome is better. Repair and meniscectomy. Recent meta-analysis comparing the long-term X-ray outcome conclude that the lateral the meniscus root repair group have lower rate of osteoarthritis comparing to the meniscectomy group. So for the management of the meniscus, we need to consider the alignment, cartilage, and the ligament. Okay, we start with the conservative treatment first. There's many options of surgery like STO, like the first audience talking about when meniscus root repair, meniscus root reconstruction, or extrusion reduction. Today, I'm focusing only about the meniscus root repair. So these are the goal of the treatment. The goal is to prevent arthritic change. Indication is in the patient have acute or chronic tear without OA. Okay, if you have OA more than KL2 joint space narrow, you should consider the STO or arthroplasty. The good candidate for meniscus root repair are the acute no joint space narrowing and extrusion less than 3 millimeters. Okay, so this is the contraindication for the root repair: subcondylar bone loss, okay, collapse, malalignment more than 5 degrees, okay, and BMI more than 30. So bad candidate for the meniscus repair is the patient that have the chronic injury, joint space narrow, there's large gap, and extrusion more than 3 millimeters. This is the systematic review in 2019 conclude that 2 factors that make the outcome worse. Number 1 is pre-existing cartilage loss, okay, and malalignment more than 5 millimeters. This is the bad prognostic. So for the meniscus repair, what is the proper timing? Say from the literature, American Journal Sport Medicine, you should repair it within 13 weeks, around 3 months. So if you have the meniscus root tear, so make a faster cure for the patient. Otherwise, if you repair it too late, it will be too late. You cannot prevent the osteoarthritis. This is my position of the meniscus repair. I break the table and drop the leg down. Okay. So before doing that, we need to do open the gap on the medial side. This is my technique published in the arthroscopy. So we call this the magic point release. So the landmark, you draw the line from the posterior tibial cortex. Okay, it's about 1.2 centimeters from the joint line. So you use a needle number 18. You touch this point, you feel the pop. So the joint will open immediately. Okay. So I'm talking about the Transceiver pull-out techniques. Okay. So this is the Transceiver pull-out technique. I published this technique in arthroscopy. We call this the pull-out repair with the use of tibial tunnel suturing technique. So this technique is very easy and simple. So you pass the suture into make a transtibial. I make a posterior portal, and then I use the tibial tunnel, use the meniscus needle, pass the suture into the tunnel. So this one is a single tunnel technique, and tie the button. Okay, tie it over the button like this. So now we are talking about the double tunnel technique. Okay, this proposed by Professor Laprade. Okay, he is the one, he proposed this technique because you can increase the contact surface, proper tension, and stable tibial fixation with the endo button. Okay, so this is the two tunnel transtibial pull-out technique. Okay, I show you the technique. So
using the open ring curette, clear away any remaining tissue and cartilage at the site where the meniscus will be.
This is the technique from the Smith nephew. Make arthroscopic and then make a good raw surface.
Fixate the tip aimer where the most posterior tunnel will be placed.
Make a tunnel.
And align the bullet externally on the tibia, just medial to the tibial tuberosity. Affix the cannula to the drill.
Fix cannula to the drill.
And drill up through the bullet until the drill breaks through the surface of the tibial plateau.
The bullet. So I recommend you to use the stopper. Okay, that's a Smith nephew stopper. You can use this stopper, okay, for very precise drilling, okay, to prevent the vascular injury.
And the aimer, slide the offset guide over the cannula through the middle hole.
Slide it, take it out. So then you can pass the suture into this tunnel.
Select the desired distance between the two tunnels from 5 mm to 7 mm.
Okay, this one is the parallel drill guide. Okay, you can have 5 mm, 7 mm. Okay, depending on your first hole. Okay, so this is very easy and very useful. You guarantee that it's parallel. Okay. And the distance for this one, we use 5 mm.
Drill the second tunnel interiorly directly through the offset guide.
Okay, do it to the offset guide. So now you have two tunnels. The benefit is that you can increase the contact pressure, like you do double roll rotator cuff repair, the same thing. It's not the point contact.
First, choose whichever first pass
contact. Okay. So after that, you pass the suture into this
straight, right curved, or left curved.
First pass. Okay. There's a straight
ultra tape or number 2 suture is easily loaded into the bottom jaw of the first pass mini suture passer. By simply squeezing the hand trigger, the preloaded needle will pass suture through the tissue into the self-captured jaws.
This is a self-captured jaw. Okay, like that way. Okay.
Monofilament may be used to shuttle the sutures down the anterior and posterior tunnels.
So this is the they use
to complete the repair, tie the sutures over an endo button.
Over the button, like that. Okay. So that is the technique proposed by Laprade. Okay. I do a little difference. So this is the concept. It's the area contact instead of the point contact. Okay. Comparing the single tunnel and the double tunnel technique. Okay. Same like you have a single roll rotator cuff repair or double roll rotator cuff repair. Okay. So I show my techniques. This is my double tunnel transtibial technique. Okay. I'm starting with the arthroscopic examination. Remove the fat tissues. Okay. Fat tissue was debrided to have the good exposure. Okay. You have the good lateral side. ACL is good. PCL also good, right? This is a lateral meniscus intact. Okay, and now looking to the medial side. The problem is the medial side is very tight, right? You see, you cannot work if you have very tight space like this. So I recommend you to use the magic point I propose in arthroscopic technique. It's 1.2 centimeter from the joint line. You drag the line from the posterior cortex to the adductor tubercle. Okay, like that. So this is a magic point. Okay, this is in the posterior joint line. Then you use number 18 needle. Okay, if you touch the light point, you see pop. See, so now you have enough space. And then I use this, we call this the medial portal. Okay, this is the portal that I can facilitate and can do the suture management. Okay, it's a medial portal just above the meniscus. Okay, and then you use a knife to open this. The benefit of this portal is that there's no fat tissue. Okay, and you don't need the cannula. Okay, so this patient have the meniscus torn. Okay, it's loose and floating, a little fiber left. So after that, I use a cullet. You can use a ring cullet. Okay, identify the anatomical position of the root. Okay, make sure that you have enough good surface contact. This is important because the meniscus cannot heal on the cartilage. So make a good bed for the meniscus to repair. Okay, and after that, you check the mobilities of the meniscus. This is good candidate because the patient have good cartilage. There's no joint space narrow. Okay, like that. You do the first hole. Like that. Pat the suture. I prefer to use different colors of suture, and then you use the offset. You see, I use the 5 millimeter offset. Okay, 5 millimeter apart. So then you drill the second hole. Like this, you can rotate. Okay, and drill. You see that? Now we get the second hole. It's the blue and the black, so you're not confused, right? And then try to repair your meniscus. Use a mini first pass. So use a shuttle. I prefer to use a tape. Okay. This one. Then you pat the suture in. Okay. Use the tape. Okay. And then you pat the suture into the tunnel. Okay. I try to make only 2 holes in the meniscus to prevent the soft tissue cut through. Okay. So first we drag the suture into the first hole like that. That's the first hole. And to the second hole. So you have like area contact. Okay. And then I pack the second suture. And use the shuttle to pat the suture in. Okay, like that. So finally you have like suture bridge, okay, for the double row repair. Okay, then you pat the suture into the button, right, and tie it to the post. So when tied to the post, careful and use your scope to see that the tension is not too much. Okay, that is a cortical button. Okay, so that's the final repair of this. So from the study, they found that the meniscus root, if you use a single row or single tunnel, sometimes it's not adequate because there's a shiny white fiber. This shiny white fiber accounts for 46% of area and 37% of the strength of the native root. So this single tunnel doesn't incorporate this supplementary fiber. Okay, so they recommend the double tunnel. Okay, for this meniscus root. From cadaveric study in 10 pairs of cadaver knees, they found that the two tunnel repair resulting in 10% higher ultimate failure load comparing to the single tunnel technique. And the clinical outcome 2.5 years follow-up, they have significant improvement in Lichholm score, Techner score, Womack score, and high patient satisfaction. And the patient less than 50 and more than 50, the result is the same, right? So this is a very interesting technique. Another preferred technique is using the soft anchor. I prefer to use the Q-fix from Smith Nephews because we don't need the posteromedial portal, no tunnel convergence, and also no bungee effect. Okay, so this is the example of the Q-fix for the meniscus root repair. Okay, I use the drill holes. This is Q-fix, right? You remove the Q-fix from the handle, and then you suture the Q-fix with the suture. So the good thing is that you just drag it in instead of using the handle to tap it in. Okay, because you have limited space, and you can use the knot tying like this. This is the using the Q-fix technique. Okay, so another point for the meniscus repair together with HTO, because sometimes you have the patient have the condyle damage. Okay, and there's meniscus root tear. So if the meniscus root tear is not too bad, I would prefer to repair the meniscus root together with the HTO. I prefer the one leg standing wheel to detect the axis of the knee, because sometimes you do two leg standing wheel from this article. It's not the real axis of the knee. One leg standing wheel represent the real axis of the knee. Okay, so the indication for the HTO with root repair is a complete root tear within 6 months, extrusion less than 5 millimeters, and the KL is less than 2. Okay, so this is one example of the patient that have meniscus root tear. You see that there's a ghost side, crepe side, and extrusion. So this patient, when we get in, we found that the patient have the meniscus tear. So we do the meniscus root tear, and very important, you need to protect your suture. I use the endo button reamer, protect my suture all the time like this. So when you use a chisel or screw, you will not damage the suture, right? This is a trick, and this is 6 months after the surgery. The patient can walk and the range of motion is returned very fast. Okay, so that is another option. So if the patient come to you late, okay, like the first patient, first doctor mentioned, if you have cartilage lesion, yeah, just root repair is not enough. Rehabilitation after surgery, we need to be very delayed, like toe touch weight bearing and limit the motion, 0 to 90 for 6 weeks, progressive weight bearing 6 to 12 weeks. Okay, no squatting, no jumping for 3 to 9 months. Okay, so thank you very much for inviting me to this wonderful meeting. Always happy to come back to China. Next year we will have the combined meeting of our Thailand Orthopedic Sport Medicine and APCAS 2022. I would like to invite our Chinese friend to Thailand next year, Pattaya. Okay, hope to see you in Pattaya, and thank you very much. 谢谢你 Bye bye and stay safe.
谢谢Bancha 教授的这个。
Thank you very much, Dr. Bancha. We have 2 more minutes, so can you stay for 2 minutes? We want to ask you some questions.
Yes, of course.
So Dr. Bancha, so for some of your cases, your posterior root tears, I think you did a great job.
Thank you.
Repairing them. What do you think about the healing rate? Because for many cases, there's still degeneration, right?
Right.
So
I think the healing rate is depending on the quality of the tissue, the chronicity. So if the patient come very fresh, like within 3 months, the healing rate is higher. Okay, from the literature is about 60 to 90%. But if the patient come very late and they start to have some condyle damage, cartilage degeneration, joint space narrow, the healing rate will be less. Okay, so I think the first thing is you need to consider choose the right patients for the repair. So if patient come very late, I did not recommend the patient for repair. Like the first speaker, they mentioned, if you start to have cartilage damage, joint space narrow, HTO is better than root repair. Okay, so answer your questions. It's depending on the chronicity. If the patient come very fast, come early, yeah, good tissue quality, the healing rate is very good. If the patient come late and joint space narrow, cartilage degeneration, the cartilage, the healing is not so good. Okay. But even the meniscus heal from the literatures, they found that over time, the cartilage or the KL grading is decreasing. Yeah, 1 grade after 4 years. Okay. So I think this is a very hot topic. We miss a lot of meniscus root tear, especially our Thai and Chinese, okay, and our Asian people. Our culture is sitting on the floor, right? We squat in the toilet. We sit on the floor. We pray. So I think we have a lot of meniscus root tear, and many doctors misdiagnosis because we didn't do that the MRI routinely. Okay. Answer your questions.
Thank you very much. That was very helpful.
Thank you.
So Dr. Li Jian, do you have any idea regarding the meniscus repair? I think the two professors of the previous two topics, their patients have some overlap. Can you give us any comment about that? About for the degenerative knee, if we want to do the posterior root repair, and when should we do HTO? And sometimes we can do both. Do you have any comments?
Yeah.
Regarding these two techniques?
Yes. So if you have you're asking me, right?
Actually, I want to ask Dr. Li Jian first.
Dr. Li Jian. Okay. Please, Dr. Li Jian.
Hello, Bancha.
Hi,
Yeah.
Li Jian.
I'm Professor Li. Yeah.
Nice to see you again.
In Chengdu, last epicast in 1919 in
Yeah,
Chengdu,
in Chengdu.
2019. Okay. So
Thank you.
Welcome to give us a speech. You are very good speech.
Thank you. 谢谢你.
We hope to see you in Pattaya. Okay.
Okay.
See you.
See you soon in Pattaya.
好，刚才我们陈彪教授提的
Good. Dr. Chen Biao gave us a question. We should evaluate the knee if there's any OA, if there's OA and meniscus lesion. What's our treatment? Dr. Bancha gave us a very good lecture for the patient with more than 5-degree volus, and if the degeneration greater than grade 3, so we should do HTO and then do repair. For the patient with good alignment, and if the degeneration is lower than grade 2, we can do simple posterior root repair. But during the repair, the tension should not be too large. Because there's a lateral extrusion force. If the force is too big, the repair will fail, and there will be new lesion. So we should evaluate the alignment and the cartilage height. If there's a cartilage height loss, there will be higher force to push the meniscus, and there will be higher rate of failure. So if you control the tension well, and that will protect the cartilage. and it's easier for us to repair, and it's good for healing. This is my opinion.
I totally agree with you, Dr. Lee.
好，谢谢建哥啊。
Very agree.
正好我们
Thank you, Dr. Li Jian. And we have Dr. Xu here. If we joint surgeries, we believe that if we do joint replacement, we can solve everything. So if you see a patient, what's your opinion regarding the HTO and the UKA? Sometimes the patient is indicated for UKA as well as HTO. What would you choose?
That's a good question. Good question.
是这个就是膝关节骨关节炎的机体治疗。
对于，也就是说，这是一个that is to say, this is a ladder treatment between UKA, HTO, and total knee. And what how do we make decision between HTO and UKA?
这部病人做 HTO 单科的，要把 HTO 的这个交界病人做。
Sometimes that depends on the opinion of doctor, but I think
几个方面考虑。
I have following considerations. First, the age, the occupation,
平常的运动状态。
and their sport demands.
方面考虑以后，加
We consider these three factors, and we should say,
膝关节内侧建设的前内侧的骨关节。
and we say that UKA solves the bone-to-bone lesion of the anterior medial knee, and the varus should not be over 15 degrees.
那你做单科
If there's very big varus, the UK shall fail,
来解
definitely fail, because you cannot solve varus deformity by UKA.
HTO
But HTO,
一定
the principle of HTO,
我想不能像
for a lot of HTO doctors, they say that we can solve every bone-to-bone
建设的骨关节炎。
lesion by HTO, but I think this is wrong.
MT 就是这个内翻畸形可以
I say that
大于15度，
the varus
小于大
can
小于
greater than 15 degree and MTA lower than 85 degrees.
HTO 是
So I say HTO are indicated for not very severe OA and with big varus deformity
TTI 角小于85度，
and MTA lower than 85 degrees.
它不能去治疗
So this is the difference.
病的内翻畸形。
And then the UKA cannot solve the varus deformity, very big varus deformity.
这个病人明显的
And also, HTO patients should not have very big flexion contracture,
Mhm.
and the UKA cannot have very big varus. That's the first one. And second one is that
随着全世界对
with
CR 技术的越来越推崇，
the development of CR technique,
重的骨关节病人
I say that for
年龄大，
very severe OA patients,
通过 HTO 单科
I do not suggest HTO or UKA. Now we have CR technique, so TKA is indicated for more than 95% of patients with CR technique. Thank you, Dr. Xu. I also feel he showed us a lot of techniques of CR technique. We are very impressed. Because of time, now we have a tea break. Then we'll begin next session. We'll have 5 minutes tea break. Thank you.
谢谢你。See you soon. Bye bye.